Today's lecture of mine is on the elderly, particularly elderly and the frail aged. Before we move on, it's also important for us to consider some thoughts about the elderly and the frail aged in the current COVID times. And we have heard a lot, whether it is in Victoria, Queensland, everywhere. Nursing homes have been under radar. There has always been some conversation in the newspapers, in the radios, as well as in general practitioners, GP practices, about the aged care. Certainly, from the time of we have come to know that there is COVID pandemic, in this country, all the elderly have all been asked voluntarily to remain at home, or those who are remaining in nursing homes continue to remain there, and the contact has been slowly reduced. The social contact has always brought some cheer into their life, but somehow that has been reduced. This is not only in the context of the community, but it is also in the context of nursing homes. We know one thing for sure: nobody relishes the prospect of aging alone. Senior isolation increases the risk of mortality. Certainly, the feelings of loneliness negatively affect both physical and mental health. Considering aging already affects their mobility, their social activity, loneliness adds additional dimensions. Perceived loneliness contributing to cognitive decline. There is a lot of research on that. And there is also a lot of research that cognitive decline over time also presents itself through dementia, or adds itself to the risk of dementia and Alzheimer's disease. Certainly, COVID-19 has given that additional factor of social isolation. Families have not been in a position to go and meet their elderly in nursing homes. In more recent times, as you can see in Victoria, under curfew in most of those areas, they're just cordoned off. There's no way anybody can communicate. It is largely the social media, possibly the mobile phone, and that's not the same, particularly if mums and dads are waiting in their nursing home for their children and for their grandchildren to be visiting. So visitors has been a major issue, and that social isolation makes obviously seniors much more vulnerable to elder abuse. Whether we like it or not, nursing homes, of course, have never been the best choice in terms of looking after. If everybody had enough facilities, if there's enough home care available, certainly elderly would obviously like to stay at home along with their grandchildren, the pets, the family home. But somehow, in modern times, these are certain things which probably are not available. And I think in the last 30, 40 years or so, the nursing home and the homes for the frail aged, the retirement homes, people moving into retirement living, all of these things have come about as alternatives. In the context of the elderly and the frail aged, loneliness obviously causes blood pressure. Socially isolated seniors are seen to be more pessimistic about the future. The physical and geographic isolation also leads to their social isolation. And if they are isolated for a long time, as many elderly have been isolated in the community during the COVID times, they are very likely to possibly be needing long-term care in future. In around the world, of course, the elderly population is increasing, and at the same time, social isolation and loneliness in older people is also increasing. Now, what has happened during COVID? Those that live in their homes continue to be shut down for prolonged period in self-isolation, and those in care homes have also been in some sort of isolation, as visitations have not occurred and many visitors obviously cannot go. Even if you had a fat private medical insurance, you couldn't visit a doctor, and that has become an issue for many elderly people. It's important to consider how the whole world seems to have taken COVID from that perspective, that somewhere or the other, some rash statements have been made about the place of elderly, and at the same time that it is important for us to understand that the expenditures that probably have to be marked towards elderly care have also been reduced during this particular period of time. What use is to have a huge medical insurance if you are not able to utilize that? What use it is to have a good care plan that can arise as a result of the money and the medical facilities that you have got, but you couldn't use it. So what seems to have happened, at least to me, as far it appears to me, that we have returned back to a situation to understand during COVID-19 the ideology, the survival of the fittest ideology, once again has returned. The elderly are not fit, so they can be dispensed with. So we don't have to return to very specific cases of elder abuse at this point of time. There is a pandemic, and during this pandemic, large-scale abuse in a way has taken place. The fact that they have not been visited, they have not been cared for in the way in which they need to be cared for, is obviously also an important indication of human rights violation. Although one might say, look, there are other priorities. Let's face it, they don't have too long to live anyway. That is the way the rationalist, neoliberal orientations seems to have gone in. It's unfortunate, but that's the reality. Progressive eugenics is one of those terminologies that they have utilized in Europe. Spending 350 billion to prolong the lives of a few people, few 100,000, mostly elderly people, is an irresponsible use of taxpayers' money. That is how many people have spoken about, and it's an uncharitable way of looking at things. Now, What do we do? Responsible use of taxpayers' money. Wasn't invading Iraq, bombing Libya, bailing out the bankers, was that a responsible way of utilizing taxpayers' money? I think we are in education. We are educationists. We need to make elderly care a part of our education. It doesn't have to be a different social science. It doesn't have to be gerontology. Elderly care and research and training, the care workers training ought to be one of the most important things that we need to undertake. A law for senior citizens in the country, not only our country, Australia, but in many other countries, it does exist. It has many implications. Every old age person needs care and protection. And the responsibility should be casted upon society and government with fear of punishment in case of failure. The most vulnerable are in our nursing homes. They need protection. They do need care. The most vulnerable are also in our communities. They do need care and they do need protection. So one of the most dominant disciplines in the field of social sciences is this social gerontology, which is concerned with the study of aging. And you could mark me on this. Human rights and public health perspectives do intersect and certainly concern themselves with the questions of aging. Family violence, violence against women, disability, all those areas also feature in this particular area. An approach informed by older adult protection philosophy did arise out of geriatrics in medicine, and it began a long time ago in the United States. They even have Department of Adult Protective Services. Certainly in Australia, we have organizations concerned with elder issues such as COTA, the peak national organization that attempts to represent elderly rights, needs and interests and tends to be more informed by human rights. The emphasis seems to be on self-determination, autonomy and respect. COTA Australia is also a peak policy development, advocacy and representational organization for older Australians, representing every state and territory through them over 500,000 older Australians. I have departed a bit from the tradition of using previous slides and felt that we need a slightly different lecture on issues with elder abuse, and that's one reason why I started off with the COVID slides and the way I looked at it. But certainly I have drawn a large amount of my rest of the lecture from the readings that I have given to you, which are written by Carson, Rhodes report from the Australian Institute of Family Studies, Canberra, and also based on some of the WHO reports. The way in which elder abuse issues and responses are approached depends on the perspectives that we adopt. The WHO takes a public health perspective, adopts the older 1995 definition developed by Action of the Elder Abuse UK, which describes an elder abuse as a single repeated act or lack of appropriate action occurring within any relationship where there is an exception of trust which causes harm or distress to an older person. But of course, there are other definitions. A working definition, again, from a public health perspective, is more specific: an intentional act of failure to act by a caregiver or another person in relationship involving an expectation of trust that causes or creates a risk of harm to an older adult. Now, an older adult is defined as somebody over 60, and within Australia we take the ABS classification and we discuss elderly and their issues once they are 65. It also provides the definitions of specific types of abuse, the WHO, sorry. A commonly applied definition applies, that is adopted also by the Australian Network for Prevention of Elder Abuse, specifies that elder abuse is any act occurring within a relationship where there is an implication of trust which results in harm to an older person. Abuse can be physical, sexual, financial, psychological, social, and or neglect. In Australia, the definition of older Australians is consistent with the Australian Bureau of Statistics, which classifies pensioners from 65 onwards. For Aboriginal and Torres Strait Islander people who have been having substantially lower life expectancy than the non-Indigenous people, a lower age for those who are older is considered appropriate. And this has ranged from 40 to 50 years. At a more complex level, there are many other constructs that are used. One of them, of course, is capacity. It's a multifaceted construct involving a debate whether age should ever be defined aspect of an elder abuse or whether it should be conceptualized on the basis of an assessment of capacity for self-care and self-protection. This is very, very important for us to do, for us to understand, and this is part of an ongoing debate. Let us view the elder abuse from an interpersonal violence model, a model that we have talked about even in Domestic Violence Lecture 2, which is as a result of interactions between those 4 levels of influence: individual, relationship, community, and societal. Similar to what we saw even in the previous lectures, and as it used to happen against women. At the international level, the World Health Organization also reported that estimated prevalence rates of elder abuse have been high in both high and middle income countries, and they did range from 2% to 14%. The prevalence rates for the most common type of elder abuse has been for physical abuse, sexual abuse, psychological abuse, and also the frequency of severity in some of these things has also ranged from 1:6%. One of the most important abuse, and which is a major concern and unfortunate issue, is financial abuse of the elderly. neglect of the elderly. The, these prevalence estimates are based on data sources involving elderly people living in private and in community settings, and do not, of course, involve any institutional care of those with cognitive impairment. Certainly, as long as a person lives in the community, in his own house or in her own house, there is the possibility of a certain amount of financial exploitation by the carers, and unfortunately also by family carers. In one of those UK studies which was done on a face-to-face interviews with over 2,000 people over 66, the study measured the kind of experience the participants had and the kind of mistreatment that they received in the preceding 12 months. And the results are, the mistreatment was at the hands of a family member. The mistreatment was at the hands of a friend. The mistreatment was at the hands of a carer. That is rather unfortunate. Overall, the 4% of population that reported mistreatment was defined, was again redefined and reclassified, and that consisted of 4% of women and 1% of men. So vulnerability wise, you will find that when we subject aged, frail aged as well to the intersectionality, you would find women are probably mistreated a lot more than that of men. In Australia, there are two population-based studies that have yielded some insights into the extent to which older women experienced violence. But there are limitations in these studies based on the measures that they used and the extent to which they assessed the concepts relevant to elderly abuse. In Queensland, there has been a lot of telephone calls for helplines. The age group of people who have asked for helpline, who have made calls to helpline, was between 80 to 84 years. And that's about 23% of them, followed by age group of 75 to 79 years, which is about 16%. Now, in most of these cases, the perpetrators were males. 50% of the calls were from females, and 9% of them were exploited by spouse and partner. 21% of them had exploitation in a combined way by neighbors, by friends, by workers, and informal carers. The most commonly reported abuse in Queensland studies has been financial abuse. It accounted for almost 40% of the reports compared to 35% of psychological abuse. The next most common type is neglect and social isolation. That was about 10%. Physical abuse was under 5% and sometimes also gets underreported. Sexual abuse was referred to by 1%, where the perpetrator was either a partner or a spouse. The most likely form of abuse has always been psychological. The perpetrators were adult children. Financial abuse was 39%, and the National Aging Research Institute has done some of these studies even in Victoria, which tried to see the measures and found the measures to be their vulnerability, coercion, dependency, and dejection. These are the variables that they looked at. And they studied people with the sampling frame that they took up from Medicare, those who are born between 1921 and 1926. In those studies, it was clearly shown that there is a slightly lower level of younger age, that is 70 to 81, and these people provided many calls to seeking help from the helplines. Elder abuse is very much in it's very much it's common in many societies, but the way in which it is increasing as a result of financial as in the form of financial abuse seems to be something that that we need to be really thinking about. Women most commonly report that their concern has been with the family members' abuse. Their own children have abused them. There were 26% of them who were talked about sons abusing them, and about 21% of them who were talking about their daughters abusing them. I think one of the important things that we also need to consider is the process of cognitive impairment or other disability, cognitive impairment and other forms of disability. They also need to be established in understanding the needs of the frail-aged and also the needs of the elderly in figuring out where the abuse seems to be happening. If the diagnosis is available, then certainly some medical interventions would be possible, and also if they are in nursing homes, maybe there is an element of safety that can be added on. So the most important thing which we have discussed before was also with the issue of capacity. Capacity in a narrower sense is a central concept. This covers legal, medical responses, the ability to make decisions, the ability to say no, the ability in broad terms to make reasonable decisions about themselves and about how they need to be proceeded with as far as future is concerned. So that's an important issue. And there have been some studies which were done in Europe, and they try to link between psychological abuse and financial life events over time, resulting in further social isolation and increasing the vulnerability of people, particularly the elderly themselves. So elder abuse has a range of physical, psychological and financial consequences. It does result in pain, injury and even death, and is associated with higher levels of stress and depression and an increased risk of nursing home placements and also hospitalization. Higher levels of psychological distress and depression than their peers. Decline in physical health coupled with decreased resources for managing their health care. So when you compare those who live at home, in their own home, with those of them who live in the nursing homes, there are again differences. In some situations and in some studies, probably the deterioration, cognitive decline has occurred quite rapidly when they were living by themselves, and also in some cases further decline has occurred also in the nursing homes because of the lack of understanding and lack of demonstrated individualized understanding of each, individualized treatment of each of the nursing home, the persons who live in the nursing homes, or in other words, the residents of the nursing homes. So if a nursing home does have a differential treatment in terms of a few people in being in a position to take care of themselves vis-a-vis the others who probably require a little more prodding and a little more care, but in order to, from the point of view of efficiency, if they push everybody around in a nursing home, that could also result in individuals losing their existing capacity and others perhaps not utilizing the existing capacity. So it is quite possible that one could lose some skills which you would otherwise would exercise when someone else is actually taking care of yourself. So these are some of the issues that generally present themselves. Now, there have been a few other studies and also risk factors that have been identified. A family having a strong sense of entitlement to an older person's property or possession is an important issue again. A family member having a drug or alcohol problem is another issue because it presents itself as abusing the elderly. An elder person feeling frightened of a family member, younger family member, who might have other problems, that is also an important issue. An older person lacking awareness of his own rights and entitlements is a major issue. Retirement is also a major issue for those who have worked for a long time and have given up their work. And at that point of time, lack of vocation obviously makes a fair few demands on their abilities. The dynamics of dependence are also relevant. Since an aged person may be reluctant to disclose abuse by someone on whom they are dependent for care. Since disclosure may mean withdrawal of the care at potentially an unchosen change in living circumstances. It is, I think, very similar to domestic violence. Why is it that people do not report? Why is it women don't possibly report? Why is it that they live in an abusive relationship? Because they don't know what would be the future, and they probably are afraid of dealing with something which is unknown. So cognitive impairment may also mean that an older person is unable to disclose or is also not believed when they do disclose. I've seen this happen personally, and I can tell you that it is very, very difficult for some of us as social workers who can see that there is a lot that the individual wants to say, and you can get that through the eyes, but there's a lot of dominant people around in that kind of a family home. You would have attorneys, you would have lawyers, and you would have a whole lot of other possibly allied health people who probably make some decisions which may not necessarily go in favor of the client that you wish to pursue. And sometimes this is where I would call it complicity of decision making. Cognitive impairment also means that an older person is unable to disclose or is not believed when they disclose. In Australia, this is still a big subject of debate. Apart from limited obligations in relation to specific offences for Commonwealth funded care facilities, there are no statutory mandatory obligations on professionals to report elder abuse. And that is something that we probably need to think about. Reporting pathways are acknowledged to be complex and confusing, both for members of the community and also for the professionals. Duties in relation to reporting depend on the professional context in which elder abuse is discovered. So uh, it is important for us to think about whether a mandatory reporting can be brought forward. One view is that mandatory reporting is paternalistic and detracts from the autonomy of the elder involved. This position is predicated on the view that the elder is the best position to make a decision about whether abuse should be reported, and derogating from the position reflects an infringement of their human rights, particularly the right to self-determination. Now, it's an important issue again for us to consider: when is it that the right to self-determination can possibly be superseded by care and care, the definitions of care. Although some organizations and individuals suggest that mandatory reporting might be an appropriate response where elders have diminished capacity. Now, how do we know what is the level of capacity? At the time of abuse, at the time of reporting, it's very difficult for anyone to make a sound capacity judgment, because it's an anxious moment. Anxious moments continue for a little longer. So there are difficulties impaired. There are difficulties at that point of time, even for anyone to make those kind of judgments. ABS data derived from 2011 data, especially the census data, sets out projections for the aging in our society, and it does tell us that the older Australians have increased significantly as a proportion to the total population, reaching about 15% in women and about 14% in men in June 2014. And the proportion of people in the age group of 85 seemed to have tripled in 1971, and a combination as a result of improved life expectancy and also fall in the fertility rates that were there since the 1960s. One of the important things that we also must consider and try to understand is about the Charter of Care of the recipient's rights and responsibility. The Charter of Care recipients' rights and responsibilities, particularly in the context of residential care, each residential care recipient does have a full and effective use of his personal, civil, legal, and consumer rights. They have a right to quality care appropriate to their needs. They have a right to full information about their own state of health and about the kind of treatment that they are going to have. They obviously have a right to be treated with dignity and respect, to live without exploitation, abuse, and neglect. Even after going into a nursing home, if you get neglected, where else can you go? To live without discrimination and victimization, and without being obliged to feel grateful to those providing his or her care and accommodation. It's sad how many times you would find that elderly are almost seen in some of the nursing homes as if they are begging for care, whereas it is their right and they have paid for it. Their personal privacy, to live in a safe, secure, home-like environment, to be in a position to move freely, within and outside the residential care services, if as long as they can do so without any undue restrictions. I get a bit emotional on this because I've seen a lot of elder abuse as I was working in the field of disabilities, and I tried to understand. On one side, the families had children with disabilities. That was basically as part and parcel of my care and duties. But then they had their elderly in nursing homes, and they had, of course, they had visitations and everything. But some of those nursing homes were definitely appalling, and the standards obviously were much, much below the expectations. To be treated and to be accepted as an individual, to have his or her individual preferences taken into account and treated with respect. Now then, the other thing that also bothers many of us is Australia is no longer a monocultural country, and it has never been. We have had indigenous population, we've had Torres Strait Islander population. We have so many of these migrant families that come into the country, many cultural, from many cultures. So the continuation of those cultural and religious practices, and to possibly have a language of his or her choice, is also an important issue. Unfortunately, that's an issue which remains it doesn't remain on the as an agenda item at all. We do talk about cross-cultural diversity, but somehow when it comes down to servicing, there is still something not very effective, and it appears as if it is a lip sympathy. So to select and maintain social and personal relationships with anyone else without fear, without any criticism, without any restriction. To have the ability to speak freely. To maintain basically your own personal independence. I think these are very, very important. Even if you are elderly, you have a right to belong to an association. You have a right to go out. You have a right to be taken out to any of those activities which you were previously involved. Some personal involvement in daily life, in the financial matters, in the running of the residential care itself, in relation to the accommodation, the kind of accommodation. I think this is very, very important. And I think that is something that we need to take it up a lot more seriously. I know in social work we have students in different age groups. We have got mature age students, mature age staff like me who are teaching. They are very young students too. There are millennials. There are possibly even, what they call the Z generation, very young generation. But we are in social work, a big responsibility. One day we will be looking at aging ourselves. It's important for us from that perspective to think, what is it that is right that we could do in the current situation, in any situation, that possibly will become an exemplar for the future. And I think on those thoughts I'll leave this lecture. The wonderful readings. There are some disturbing videos, but then of course you know it. Social work is not an easy field. It's because of the problems and because of the concerns we are in this. We are bound to be disturbed. We generally seem to be in crises, and our profession seems to be in, out of crises. Thank you.